Good afternoon, everyone. Thank you so much for joining us for today's webinar. We're going to start in just a few minutes and give folks time to log in via Zoom, so stay tuned. All right. Well, thank you so much for joining us today. My name is Jessica Holsey with the Addiction Policy Forum. I'm very excited for today's webinar, Emerging Challenges in the Treatment of Substance Use Disorders, a Q&A with Dr. Mark Gold. A couple items just on housekeeping before we get started. This webinar is being recorded, so we'll make sure to send the recording out to all of our attendees as well as registrants later this week or early next. In addition, you will receive a certificate of completion for attending the webinar today that you can submit to whatever accrediting body that you might need for CEU credit. And if you have any questions, please let us know. For asking questions for our expert today, there's a Q&A icon on the Zoom screen below, so you can enter your questions there. Just due to the number of registrants, the chat is disabled. Today's webinar is part of our science series, where we feature leading experts in the field of addiction nationwide. And I'm very excited that I get to introduce you to our guest speaker, Dr. Mark Gold. Dr. Gold is an important mentor of mine. He's a member of the Addiction Policy Forum Scientific Advisory Board, and he really is a prominent figure in addiction and psychiatry. He's celebrated for modernizing addiction medicine training. I think he has over 1,000 peer-reviewed publications published with over 30,000 academic citations. His work in our field is truly groundbreaking. Dr. Gold's been on Oprah, I think 3 times, has been the leading expert when it comes to addiction for not just one, but several presidents and White Houses, and his pioneering research on opioid dependence and opioid use disorder has led to groundbreaking theories on addiction and withdrawal. He's revolutionized psychiatry by introducing evidence-based care as well as medications for addiction treatment. He's really helped us also understand cocaine's impact on the brain and the dopamine system, and help structure evidence-based care for stimulant use disorder. He's a visiting professor, an editor, a researcher, a good friend, and his influence on the field of addiction and translational neuroscience is really second to none. So we're really excited to be able to have Dr. Gold join us today. We're going to sort of hear a mini lecture from Dr. Gold and then open it up for Q&A. So at that, Dr. Gold, I'll hand the Zoom mic over to you.
Well, thanks, Jessica. And really, first of all, I love the Addiction Policy Forum, and I really am a fan of the work. I'm a fan of the mission, and I'm really proud of the research that Jessica and APF have been doing. It's making a big difference. We have so many data gaps. So first, let me say, for anyone who's ever heard me speak, my voice may sound a little off, but I'm recovering from community-acquired pneumonia. So I do have a little residual effects of that, and I'm grateful that we could do this by Zoom, so I didn't have to get on an airplane and put my immune system at risk again. So I'm going to briefly go through some work and just as a background, um, and then kind of see where it goes. Because asking the expert seemed like a lot of fun when Jessica proposed it. She said, "Well, how do you feel about just coming on and answering questions?" And I said, I feel good about that. And if I don't know the answer, I'll look it up and get back to you later. It's all fine with me at this point in my career. So I let's see. I had a 25 years at the University of Florida, for anyone who's in Florida, and founded the Division of Addiction Medicine. And but my career, as Jessica says, mostly in translational research. I got very lucky in that we started a addiction treatment program for health professionals, and it gave us a chance to study them and maybe look at addiction in the context of health professionals, what recovery looked like in health professionals, and then training programs, so that no, so we all of these really gifted and talented people could be kept in our field, and it has really been great work. And Bob DuPont and Tom McClellan have captured a lot of the essence of this work, but it showed pretty clearly that recovery was possible with enough support. Let's see. I guess I have to use this. Um, we got 60 years to celebrate in the Department of Psychiatry, which was great. And I'm happy to do that. So, when you have a successful research career, it happens because of your mentees and your collaborations. And so for the young people on the Zoom today, keep that in mind. You're when Jessica says I'm an important mentor for her, that means she's an important person for me, and her interests are my interests. I may not have picked a project, but if a mentee picks a project, it's my project, and I'm all in. And that's actually how some really good things happen, because you bring your point of view and you get to amplify it. So these are just some of my collaborators. Bart Hubble at Princeton, Jessica's alma mater, and I work together on what drugs of abuse might do in the brain and how that they're like food and sugar. And with Nicole Lavina, we shared that student, and now she's a professor in her own right, looking at sugar and how foods can addict us. A couple of my Yale colleagues up here, John Crystal, who also worked in George Agajanian's lab, was over to the right, and uh, really invented the use of ketamine for depression. So there's a whole science of the use of agents in safe and effective ways, where it might be a drug of abuse. Certainly, ketamine is a drug of abuse. The date rape drug. It's been associated with all sorts of abuse stories, but at the same time, when used appropriately, could be a lifesaver in medicine. And even today, there was a paper out that said that its effects in serious depression were long lasting as far as suicide prevention. And Benny Prim, you may know Benny and his daughter Annelle Prim, who's quite prominent in the American Psychiatric Association work, but he helped me understand medication assisted treatment in New York City when I was growing up as a boy. And then all my younger mentees, I could give a talk on all of them. You'd like Jessica down here, but on our SAB we have a lot of these wonderful people. Uh, you know, I'll start on the left. And so I've collaborated with Phil Hemphill on sexual compulsivity, and Jean-Luc Cadet since he was an intern at Columbia University, on methamphetamine, and Adrian Brungiel on secondhand smoke, how secondhand smoke is really firsthand smoke that you didn't give consent to. That's really our work. And Brian Furline on how you might streamline opioid treatment, and Chris Hammond and in child and adolescent, and the whole list. This Josh Siegel, who just had that wonderful report in Nature on how psilocybin might reset your brain. And of course, Nora over here, who I had the great pleasure to meet when she was a psychiatry resident at NYU. A whole host of Sarah Vincent. She's on our board, right, Jesse? Yeah. And who's done just amazing work and is the new chair uh, in Atlanta. So all these people have really made the career possible. And of course, the good news here, I have 4 children. Maybe all of them are mentees, but this one is the first one to go into psychiatry. So I particularly like that. And she's taken up the mantle of stigma in mental health, and a stigma in mental health for healthcare workers. I'm very, very proud of her. So uh, I'll go through some of the key papers, and it'll give me a chance to highlight some work that I think is interesting and we could see come up in the questions. So I said I've worked forever with Jean-Luc Cadet, like since he was an intern. If you see his CV, I think I'm the first 2 publications. And then like any great mentee, they end up being much better than you. And he would periodically throw me in a paper of his and we would talk about things. But we did write a cover paper for biological psychiatry on how all drugs aren't the same, and some drugs might leave a residual after the person stopped. And this work of his, it's his lifetime work, it is about how methamphetamine might be more like head injury or more like a concussion than other drugs, which don't leave the same residual. Um, Great work. With Ed Kansian and I both debated this point, and this is still of considerable interest. Do people use drugs or certain drugs because they have a pre-existing psychiatric problem? Like, do people who are depressed use cocaine or methamphetamine? And the opposite being, do people become depressed because they use cocaine or methamphetamine? And these are both true. I, with Cadet, have looked at this and thought most of the examples are the drugs which target the brain's pleasure system, after all, cause changes in that system and make depression more likely. So a post-addiction state is often anhedonic. The inability to appreciate pleasure in the way that you did before is often sad or depressed, regardless of the drug, by the way. All drugs might have this effect. This is Cadet in my cover. We even got to make the cover art, which probably is very confusing, but it was a lot of fun for me anyway. Um, and John Cadet has done great work on this, even to the point that they've finished a post-mortem study of Japanese uh, military veterans who took methamphetamine as part of combat, I believe. And this work has now been done by Cadet, by Thanos, Volkov, and others to show that at certain doses, maybe a binge dose, methamphetamine causes effects that are very difficult to reverse. And we may see this as possible in other drugs, but it's rare. Methamphetamine stands apart from other drugs. And I have a whole bunch of papers related to this, maybe 10, 15. That's part of what people don't really get about academia. Like, it's not just one paper. We basically do these in a row and try to make a story. And for someone like Jean Cadet and methamphetamine, he's been putting pieces together in this story for many decades. For opioid use disorder, my career started in about 75, and we had naloxone for the first time in the Yale New Haven Emergency Department, and it was an orphan drug. There were so few opioid overdoses that the company that made naloxone thought that there would not be a market for it. And so they ended up interesting anesthesiologists in using it and carrying it into surgeries where they were using opioid drugs to like just lighten the patient up or to bring them out of it, because naloxone is a wonder drug that basically kicks opioids off of the mu receptors, after which allows the person to wake up and breathe and so forth. It is really a remarkable. It's short acting, and we learned about that in the emergency room too, because sometimes we would reverse an overdose and the person then refuse treatment and walk outside and overdose again in the parking lot. Not by taking more drugs, just because the naloxone wore off compared to the activity of the drug they were taking. But that was kind of my career, and Kleber first trained me and then asked me to run the methadone program at that time at Yale. And we had methadone at that time, naloxone, as I said, in the emergency department, and we were studying naltrexone, the long-acting naloxone-like compound at that time in opioid use disorder. So it's a pretty interesting when you think back. Many people have just entered the field and don't realize that we've had these treatments for decades. The difference is we haven't really made them as widely available as they are, and we haven't had as many patients with opioid use disorders. I met Nora around my work, the so-called dopamine hypothesis. And you heard Jessica say that we proposed the idea that dopamine was essential in cocaine addiction in 84, but the context would be that in 84, the American Psychiatric Association and Organized Medicine said that cocaine was not addicting. The DSM, if you're familiar with the psychiatric diagnosis system that's built around DSM, the research diagnostic criteria, which was the harbinger of the DSM, said cocaine was not addicting. The DSM first version said cocaine was not addicting. The DSM second version said cocaine was not addicting. And the DSM third version said cocaine was not addicting, all because addiction was not defined as this pathological attachment, this like, some new lover, something that you're attracted to that's going to kill you, the continued use despite consequences. It was defined almost exclusively on the basis of alcohol-like or opioid-like withdrawal. So if you didn't have a big withdrawal syndrome like that, you weren't considered addicting. So the dopamine hypothesis allowed us to recategorize cocaine as addicting, but also made it possible for us to have behavioral addictions. If everything was just stuck in benzodiazepine withdrawal or alcohol withdrawal or opioid withdrawal, if that was the only way that you could have an addiction, we would be quite limited. We've done some work on drug prevention and some education of physicians. George Koob gave me one of his postdocs, and we were able to set up a smoking lab at the University of Florida, which was really great because we had smoking rats. So they could smoke tobacco and smoke cannabis. And we were able to show all sorts of things that you can't show if you inject an animal with nicotine. Because in fact, tobacco is not just nicotine, even though they call it nicotine dependence, or it's a lot more than that. The same thing for cannabis. Cannabis is a lot more than THC. So we were able to study all of that and also show, by the way, that secondhand exposure did produce physical dependence and addiction. And you could provoke withdrawal by giving the cannabis dependent secondhand smokers anandamide, a cannabinoid antagonist, and do the same thing in humans. We, by the way, sent a group, I don't know if I have a slide here, but we had a 5-year study in Afghanistan of opioid smoking, principally women, and studied because they were the secondhand exposed group. The husbands smoked, the wives were the secondhand exposure, and we studied also their children and showed in that situation that children born in that house also developed opioid use disorder from the secondhand smoke. Brian Furline, who you already had on, the Lisa Merlo, who is a graduate student and then psychologist, is now wellness director and has done wonderful work in helping us understand the recovery process around impaired health professionals, but also she did what I like this the best, alcohol consumption associated with collegiate American football games. She did studies of people who were tailgating and almost could make we used to say that you could tell who had an alcohol use disorder by who was the first one at the bar when the bar opened in a party. And she said you could tell who had an alcohol use disorder or alcohol problems by the students that came to the game immediately before the kickoff because they're drinking outside and waiting for every last minute. But just a big portfolio of work, and I'm grateful for her collaboration. Ben Shrivastava has worked as a researcher now at Columbia, worked on naltrexone and what the limitations might be of naltrexone, what the limitations might be of medication-assisted treatments, and what the limitations might be of just supply reduction. All of that's really good. As a mentor, I kind of like proposing ideas and then playing with them. Like an idea might be, what if we had universal naloxone? Everybody carried naloxone. How many people could you save? That's a thought experiment that could be expanded. And through artificial intelligence, you could probably come up with a number of people. That's a good number to know. And then you could see how you're doing relative to that adoption. And early on, when we were stuck with the opioid crisis, that's the kind of work that NIDA did. They thought, well, what would have the biggest impact of all the interventions? And of all the interventions, the biggest impact was naloxone availability. What would be the second biggest impact? Would be expanding access to medication-assisted treatment. The third greatest would probably be keeping people in medication-assisted treatment because the treatment's only as good as when you're taking it. If you use the analogy of opioid use disorders like a chronic disease like diabetes, you have to take your medicine. So we did all of this. We've also done thought experiments on all kinds of things. The American Psychiatric Association's council asked me to help organize a group to think through what were the risks and benefits of cannabinoids. And with Kevin Hill, a wonderful mentee who's the head of the addiction psychiatry group at BIDMC. We thought about this for a year. We looked at all the peer-reviewed literature for a year. And at the end of the day, we said, it's so odd. Like the approach to cannabis is so unlike the approach to ketamine. The approach to ketamine has been to find a safe and effective dose, to find a route of administration with the least side effects, to find a medical condition for which ketamine would have efficacy much better than existing treatments, and to do that in a controlled scientific fashion. For cannabis, rarely could we find any evidence for any benefit in any condition on the basis of well-conducted trials. And our report was not that cannabis would not have an approved use, but that it doesn't have one now for good reason. But nevertheless, that doesn't change the use patterns, and we're evolving from one drug use to another. This is Jesse, you remember David, who had worked for a short time with us and wrote a book, and then tragically had brain cancer and died. And when he called me after his diagnosis, which basically was the kind of cancer that you were going to die quickly, we finished up some work, and he was himself a recovering person and a teacher and mentor and intellectual, and thought, well, why is it that if a person has an opioid use disorder, every time that they slip or relapse, they're given the same treatment, whereas in depression, every time they slip or relapse, they're given a different treatment? And he used this a framework that he invented to say we should have some consideration for treatment-resistant opioid use disorder and have different approaches if you fail, rather than always giving the same treatment regardless. And it was quite compelling, and people have continued with this work. With Mayo Clinic Group, I was very fortunate that they were interested in me helping them expand their division and develop kinds of treatment algorithms. And we published one of the earliest ones for opioid use disorder with this group of
Good evening.
mentees. We'll skip him, but he's a wonderful guy. And
I wish I could be there in person.
he said he would like to be here in person, but he was gonna say that I was one of the pioneers of medication assisted treatment. Thank goodness for that. Now, there wasn't very many people in addiction. To give myself credit, in 1975, if you wanted to study addiction psychiatry, no such study was possible. You couldn't even admit a person with an alcohol use disorder to the psychiatric unit at Yale. Herb Kleber and I used to see people in the emergency room and then take them to AA meetings in the community or to storefront clinics, because there were no clinics possible. And for me to even be trained by him, I had to do it as a moonlighter outside of the regular work, which was it seems so strange. One of my mentors, and Jessica, you get a kick out of this, I was going to my annual review, and my mentor said, well, what do you want to do? And I said, I'm already doing translational work in rats, and I'm interested in the brain systems and addiction and relapse and withdrawal, and maybe I'll go into addiction. And they then thought it was an emergency, that I needed to see someone and get help, because it was just such a peculiar choice that I must be having an existential crisis. But I wasn't. It was a great choice for me, and I've felt that that we made a lot of impact, not only in our research but by training so many people to be providers, and that's been really wonderful too. So my youngest daughter, as I said, has written books, and she writes for Vogue and all kinds of magazines I don't read, and she said to me, like, Dad, you have to start doing things for the general public. So uh, I started writing a column for Psychology Today, and my children critique it, and but I've been very happy with it because out of the blue, some people at NIDA and some people at NIAAA and some people have written me and said, I haven't really thought about that problem in this way. And so as of now, I have 40 of these articles up. They've been, some people have used them in high school for training, counselors. Some have used them in colleges and in classes. And I'm very happy about that. So anyway, I'll go through a couple of them, but I like one said, you could, everyone can make a difference in the opioid crisis. And we could start with giving consistent messaging. Adolescents' brains are not developed. And while they can do a lot of stuff and have great enthusiasm, that's just a fact of nature that we can't change. That their brains are not developed and drugs can interfere with this development. And uh, that's a good place for everyone to be at. While we're concentrating on saving as many lives as possible, and that's important. There's nothing more important. We have to keep in mind that that can't just be our strategy. So we have to have what's next, and what's next would be get into treatment. What's next is stay in treatment. What's next is work on other things to make your life more meaningful for you. Lastly, this is my first piece. I said drugs like opioids target the pleasure system, and that causes changes. Now, we don't know the full extent of the changes, and we don't know how long they last. But we do know this, that if you take drugs at like fentanyl or heroin, at some point in time, the treatment that we propose is safer, more effective, but similarly opioid drugs, methadone, buprenorphine, suggesting that the system is out of balance as a result of drug use. And when that system might return to the way it was before the opioid use is a question. Part of the reason for interest in some of the psychedelic approaches is because it's possible they could revert the brain back. But as of right now, we don't have a way of turning a pickle into a cucumber. The and then these are kind of my articles in order, and you can have all of them and take the content and just use them for training or anything. But it's important to use science to help destigmatize the opioid use disorder, to help people and not stigmatize them. And that will help people get into treatment. And it will help people who just don't understand develop a clear understanding based on science. We I think this is a really big change. So when Jessica and APF talk about the opioid crisis, they rightly point out that it started with overprescription of pain medicines. So it was a prescription drug crisis. But at that time, you knew what drug you were taking. Like if you bought OxyContin, it was made by a pharmaceutical company. It was in essence pure. It was approved by the FDA. And you had the number of milligrams on it. You even knew what the dose was. The next phase we morphed into a heroin crisis, then a fentanyl crisis, and now we have all kinds of pills, many of which are bought bootleg pills, counterfeit pills, and you could buy a Xanax online and get fentanyl in it, enough fentanyl to die. Is uh, and that's the basis of this one pill can kill. But it's an important change because overdoses in adolescence have continued, we think. Other key points, why would in tobacco use, we learned that the earlier tobacco companies could help kids learn to smoke, the more persistent and the better customers of tobacco they were. The same applies to adolescent use, and affects the normal development of the brain's pleasure system. I asked the expert of Brian Furline the same as you're asking me, and he said the one thing he's learned is that when you rescue someone and you have the family around, that's a key moment in time, and you could start buprenorphine in the emergency room rather than wait. A famous drug historian, David Musto, who was a Yale professor, um, said that every opioid crisis ends with a psychostimulant crisis. And so not right now, we're kind of seeing that it's not ending, but you are seeing that in the last data, um, overdoses from fentanyl had gone down, but not methamphetamine overdoses, but not cocaine overdoses. And the combination is the speedball, which really was popularized by some of the people on Saturday Night Live who used this drug combination back in the day, early days of Saturday Night Live. Um, and it's difficult to treat. Think about it. What's the treatment for methamphetamine overdose? What's the treatment for cocaine overdose? So if you use fentanyl and a psychostimulant, we might be able to give you naloxone or nalmefene for reversal of the opioid part of the overdose, but the other part, we don't have a medical treatment for. This I profile. I also, the other thing I did in the psychology today, I kind of profiled famous researchers because the field has so many new people, they don't know who they are. Jessica always says that the people don't know how to find the experts, but I've been, at the last ASAM meeting, there are over 5,500 addiction medicine physicians in this group. And I remember when there were 10. I mean, 10. Like, I remember the first American Society of Addiction Medicine textbook. I believe I wrote 7 chapters. Now, it could have been 8, but it wasn't 1. Like right now, I'm down to 1 chapter, which is more normal. How could you have 7 different areas of expertise? There was no one else in the field, but people don't know about today's life's work. And it's important, and I did point it out. And he also has done great work in racial disparities. We looked at food as an addiction, and then like in a very early paper, Kelly Brownell and I and a couple of other associates said that if you take drugs of abuse are used to treat appetite. At that time, it was be psychostimulants, right? But the same thing would occur the opposite way. Treatments for overeating should also be treatments for substance use disorders. So you're now starting to see that. We have combinations of naltrexone and buprenorphine, not and bupropion for weight loss, and similar kinds of treatments for alcohol use disorder or even for methamphetamine. So you're starting to see with the GLP-1s that it's suggested that they might be safe and effective for behavioral addictions, maybe for gambling, maybe help us with alcohol use disorder. Now that makes the most of sense because think about this. In experiments in nature, the green vervet monkey seeks out rotten sugar cane, and those animals have been given naltrexone, and that reduces their consumption of fermented sugar cane. So in a way, sugar cane, as a gateway concept. There's this bridge between a food, sugar cane, and alcohol, which is just fermentation. So they should really have very similar, uh, very similar treatments. Um, this is this whole dual disorder concept, and whether it's vice versa, what came first is less of a problem than the fact that it is so common. And it's a main problem even in people who are stable on an MAT. You go to a methadone maintenance program, and 40 to 60% will have problems with depression and have problems with depression to the point that they feel like they need treatment. And oftentimes the lack of psychiatric evaluation, the lack of psychiatric treatment undermines the overall treatment of the person because we can't really separate it. This is a one person with many problems, and we look at that. Some of the psychedelics are being tried for traumatic brain injury and also in substance use disorders as well. Genetics, there's the biggest surprise to me was just how important genetics may be for cannabis use disorder and how it might not be as important for opioid use disorder. Um, I I love this Yale group's work on cannabis and find it really compelling. That risks, especially in teens, have been underestimated. Use has been going up, daily use has been going up, and psychosis rates have been going up. Now, we've heard this trivialized, but a 50% increase. So let's say the schizophrenia rate's 1%. Again, that's a disease for which there's no cure. If it doubles, as in some countries have suggested, that would be a monumental increase, and we would not have the number of clinicians to treat it or beds for people with these disorders. So it's worth keeping an eye on this. And I spent some time talking about secondhand smoke for cannabis and so forth. There's been a lot of interest in exercise. I'm interested in exercise. I exercise when I'm able most days. Exercise should have been declared a treatment, and then we would have been able to prescribe it. We could prescribe it, people could get reimbursement for it. When Jessica and I talk about what happens after a person's addictive disease is in remission, how does their brain heal? How do they return to the person that they used to be? Exercise has to be part of that equation because it does appear that it's part of neurogenesis. It could be part of the healing process. And also it helps with dopamine. Exercise is also a great maintenance treatment for stress and anxiety. The hardest part is doing it. Like we tried at Yale to use exercise as a treatment for depression, but depressed people don't want to get out of bed in the morning. They don't feel like it. They're actually more depressed in the morning. So what we then tried was then have a buddy, have a friend, have a loved one say, let's go for a walk. Um, all of these things, uh, someone to help really makes a big difference. And you'll see that the exercise work, there's work on walking in nature, there's work in breathing, there's work in meditation, but all of this, for it to have effects on people who do not feel right, requires help from others. This work on um, exercise, Nora's old colleague, Pete Thanos, has been trying to get the dose effect. So the work has really progressed to the point that he's working on what's the dose of exercise and what kind of exercise would be the best for cocaine recovery, methamphetamine recovery. And I think you're going to see more of that. Another one of my mentees has been doing the pioneering work on psilocybin, has a recent paper on psilocybin effects on a single dose. The good news about this is it has a ketamine-like quality where serious scientific people are looking at dose, minimizing risk, looking at effects, and trying to find treatment conditions where it makes the most sense. There's ongoing work right now separating the hallucinations from the therapeutic effects. So while it seems wild and crazy to consider this, ketamine work seemed wild and crazy, and it was approved by the FDA for difficult to treat depression. And no one in psychiatry would seriously suggest we went back. It's not like you see things in the newspapers. I think I saw something today in the Washington Post where people are always saying we made a mistake on doing this or that, cannabis or this. Ketamine we needed in psychiatry. This work at Yale, and I won't have a lot of time, and I really find it great, is that we assume that male and female people with alcohol or opioid use disorders have the same neurobiology and should have the same treatments, and that's just not true. It may be they're two separate diseases that we should and separate them on the basis of gender. This work is ongoing, but it's very important. And even in smoking cessation, they're showing the same kind of thing, that response to treatment is quite different between the genders. I discussed this on fentanyl smoking a little bit already, fentanyl plus psychostimulants as speedballing, but more people are dying from smoking drugs than from injecting them right now. And that's changed the overdose epidemic and means we need to spend more time in education, we need more time in prevention, and we need to treat people who we do reverse for a long period of time. And I don't have any idea how long it is, but it is long. Jessica helped me with this piece in psychology today, and she's quoted, and I put her picture in it and so forth. But you know, the good news, was that overdoses dropped. The bad news is we have only 4% of the world's population and 20% of the overdoses. The bad news was some of the states didn't drop very much and actually increased. We could do better. But the good news is still good, and we should congratulate each other. I did write this piece about methadone. Why can't a doctor prescribe it? And I do think we're starting to get movement in that direction right now, where access to methadone may be uh, uh, made easier, which is really important. And I looked at this one in the history of methadone maintenance, who did the original work at Rockefeller University, what was the data, and why did it end up like this? The former president of the American Psychiatric Association has worked on food and gambling and so-called behavioral addictions. They're real. They're common in people who have other use disorders, and we're starting to see treatment trials from one of our SAB members, Mark Potenza, and others in these behavioral addictions. Like there might be a medication, maybe it's a GLP-1 for gambling. You've probably heard about the xylazine contamination, attempting to potentiate the effects of opioids and cause this kind of zombie effect. Jessica also helped me understand the original failed trial, talking to some of the PIs and looking to the future as we make progress, we report on what we find, we take an honest inventory of what we have, and we do better. That's the research process. This is a challenging work, but it's worth discussing in the context of today's methamphetamine work. We have to come as a field to understand, like, what should we do about overdoses? Like, should we count them? Is there a way, are all overdoses the same? Is an overdose with loss of consciousness different than an overdose with loss of consciousness in need of reversal? And some of the most recent University of Pennsylvania work, where Nora is also a co-author, shows that fentanyl overdoses are really serious, and that the oxygen deprivation can be serious and cause brain changes um, uh, like hypoxia. So think about what else do you remember, like somebody's drowning, and or have we do CPR. Well, there are all kinds of ramifications of this work and important to keep in mind. And again, as I said, shift from smoking to smoking. The best foods are the most compelling, have the most sugar. Don't forget about psychostimulants making a big comeback. And don't forget about the pioneers. This is Dave Smith, another unknown person to the new people in the field. Dr. Dave Smith coined a bunch of uh, really, he's this really smart guy. He actually led the healthcare is a right movement, and started the Haight-Ashbury free clinics. He's considered one of the founders of addiction medicine. He developed protocols for detox, and he's interestingly started as a huge proponent of cannabis legalization, and then has become very concerned about the Bay Area, San Francisco, and cannabis and drugs. But Smith's own life and work I highlight, and uh, he just categorized how the Bay Area went from the peace and love and the summer of love to being overrun by methamphetamine. Vaping, we discussed, treatments for vaping and the need for treatments for vaping, and the new work at Yale. And then how do we reconsider alcohol? So Professor Rummans, who's a board certified internist, as well as a psychiatrist, has looked at this and said that we shouldn't minimize alcohol use and alcohol exposure, and we should consider each use. So I'd say that's enough for me.
Fearlessness and cannabis.
Let me
Triggered
play
a house
this.
fire in San Diego. When firefighters put out the flames, they discovered an elaborate pot growing operation there in the garage. Firefighters say some of those marijuana plants did burn, but they also say one person was treated for smoke inhalation. I inhaled so much smoke.
It's not as funny, but it was the impetus for us to study that in animals. So you could show that secondhand smoke is real and that inhaling it is a drug exposure event, and repeated inhalations will cause changes in the brain as if you smoked yourself. And our group has been able to show that in animals for tobacco, cannabis, and opium, and in humans in tobacco, cannabis, and opium. So I think that's very important to keep in mind. Well, that's about the limit of my voice. So I'm going to try to keep it together here for some questions.
Thank you so much, Dr. Gold. We're so grateful for you spending some time with us this afternoon and covering so many topic areas. I should share before we get into some Q&A. The majority of notes and emails I'm getting are first lots of folks sharing that they went into this field because of you.
Oh,
I have two doctors, another clinician, and folks that have emailed from hospital systems and their work in the field was inspired by your work. A new email that just came in that someone's been tracking your work since 1977. So thank you for all that you've been doing.
well, thank you. My first publication in the field, I think, was 72.
Yeah.
And it was on something called, that no one knew what it was, but it was called, I called it like state dependency of memory. And what it was based on was I was wondering why people were taking speed to study. Like it was just to stay up. So we did an experiment where we taught animals something and we asked them to learn it. And we did that in a straight situation. Then we gave them amphetamine, taught them, and tested them. And then we gave them amphetamine, taught them something, gave them amphetamine again, and tested them. And what we showed was that you remember things the best in the straight state. But if you're in the drug state, when you learn, you have to be almost in the identical drug state window to recall it maximally.
Oh.
And to just bring this back to other areas of medicine, it's used to explain why mothers remember childbirth the best when they're in it again.
Oh.
So like when you're sitting there, Jess, and you're thinking about it, it's kind of an abstract notion, like the pain, the wonder, the pleasure, whatever. But when you start in that cycle of labor again, some women will spontaneously say, I just can't believe I went through this again. I know what's next, because the memory is chemically sealed and you can only really unlock it maximally with the identical chemical key.
Interesting.
That was my first paper. And I then did a paper on sleep and memory, which is about the same kind of thing where if you're sleep deprived, it affects your memory. And that was a REM sleep study believe it or not, in 73. But it is a funny thing for the people who've been following my career. Like I get to review papers like Science and various, academic publications. I'll be reading a paper and I'll go like, I showed that in 1974. And we'll write back. And then the person will say, well, you can't find it because it's pre-digital.
Oh, wow.
So a lot, even the dopamine hypothesis paper that Nora references our paper from 84 is hardly referenced because you can hardly find it. People reference something we've done more recently. But yeah,
A little factoid, and Dr. Gold knows this. That paper, the dopamine hypothesis paper, we cite it, and it's one of our like most highly accessed video explainers because we turned that whole sort of concept into a video explainer for patients and families, a cartoon. So we have to have like a library of your greatest hits, Dr. Gold.
well, my library would be the people who are in the field, and like that's a compliment to me, and it makes me feel good, and I work for that kind of feedback, and I'm grateful.
That's wonderful. So I have some questions, and we have a few minutes before we sort of close up the webinar. But before I dig into attendee questions, just sort of I'm curious from thinking through there being like 7 addiction psychiatrists, or that story you told about, you told a mentor or one of your advisors that you wanted to go into the field of addiction, and they thought they should do an intervention to make sure that you were making the right choice. So from sort of your career and seeing how much progress, like now we have addiction psychiatry as a field. Now we have addiction medicine as a field. We have professional associations. We have ASAM. We have AAAP, the American Academy of Addiction Psychiatry. We have like, and all these amazing developments. So I have sort of a 2-part question. Like, what do you think some of the bright spots are on new therapies, new treatments, medications that could really improve what the next 10 years or 20 years looks like? And then on the other side of that coin, what do you think the biggest challenges are for the next decade or two?
Well, I'm gonna not be able to cover it completely just because it's such a good question. We could do that as a whole thing.
We'll do another webinar on just that
Yeah,
one.
I mean, like you'd have to go through each drug. So in a
Yeah.
way, let's just do that quickly on opioids.
Okay.
So for opioids, we have treatments for opioid use disorder, such as buprenorphine, naltrexone, and methadone. We have injectables too. The main thing missing, and you could make an analogy to nicotine, tobacco use disorder, because we have the patch, we have the gum, we have inhalers. So the strategy of medicinal replacement is a viable strategy. The problem is when the replacement is gone, what's left? So this kind of like, can we turn a pickle into a cucumber back to being a cucumber? That is really what's missing. In the meantime, will we get something better than methadone or Suboxone or buprenorphine? That isn't really the point. The point is to take it and to get as many people on it. I don't see that as being critical. We have treatments for detox. We have clonidine that our group invented and lofexidine. And we have methadone that we can detox people with, Suboxone, buprenorphine that we can detox. So we have detox. We have detox, we have replacement. Then we have relapse prevention. You would consider buprenorphine a relapse prevention. You consider methadone relapse prevention. You consider naltrexone relapse prevention. So in a way, I don't think we're going to, unless we have a vaccine, and the problem in a vaccine is going to be females of childbearing age, the evolution of drugs and designer drugs and small changes and so forth is complicated. So for opioid use disorder, I'm thinking there's going to be work on like there's overdose work and also overdose. So we have naloxone and we have nalmefene. So honestly, I think we're in pretty good shape. We're not in good shape as far as treatment expectations, the complexity of treatment provided, the complexity of the evaluation process and looking at the whole person. We almost have like the appendix in room 5. People used to say that surgery was just such a bad rotation because the surgeons would say, now you go and look at the appendix in room 5, and when you're finished with that, go to the gallbladder in room 3, and then go to the, we just look at opioid use disorder as if it says something about the person, where I think that's a it says something, but not enough. So we have trauma and opioid use disorder, abuse, neglect, deprivation, and opioid use disorder. That's on the one hand. Then when you look at physicians with opioid use disorder, you see something else. You see anxiety and opioid use disorder, depression and existent. So in a way, I think the core, the invention side, the neuroscience from is great. We have really wonderful treatments that are not used, that need to be used more. And then we have the question, is stigma and shame conspiring to convince people who are being treated with MATs and their loved ones that they need to finish? Like, when are you going to be cured already? Well, you're still taking this treatment that must prove what it proves is that you're actively preventing a relapse. You're taking insulin. You're preventing the disease and keeping it in remission. I think that's a big problem that's not addressed. And I do really think residential treatment is also something that we haven't thought of because we're in this crisis. But now that we have methamphetamine and opioids and cocaine and opioids, we're going to have residential treatment access to get people off the streets. And the drug stimulates their own taking. So you go, and then it's over. And the psychopathology in the drug state, the violence and all kinds of things. We've underinvested in that. We're missing habilitation too. Like in the old days, no one remembers these. We had, Synanon and Daytop, and there were residential treatment programs that were years.
Oh,
And people came out with skills.
hmm.
They had careers.
Oh, wow.
They were run by church or other, but in a way it was like a kibbutz approach.
Oh, wow. Yeah. So you have that long term helping people to get towards that remission goal instead of, sometimes we have so much impatience, like we want this to be done with quickly. And so our view at both medication and treatment, length of treatments can be sort of colored by that. So we have, I think, some things to learn from some of our past models.
Yeah, I mean, you might take the opposite side. If Kleber was here, he might say that some of his greatest treatment successes were people who were on methadone for 40 years.
Yeah, absolutely. there's a couple questions that have come up in there, and I think you've just spoke to it too. So we do have a lot of tools in our toolbox, but we don't always use all of them or sort of have individualized, like holistic, sort of plans or approaches to treating the patient. But what about that question about how long people should be on medications or not? I don't, it's so interesting. If it's preventing relapse, it's keeping someone in remission. We don't really put pressure on patients or families to come off insulin or to come off antidepressants. But then we see that in the addiction space, like this question. So how do you
yeah.
respond to patients about that?
So, I mean, some of that is based on stigma
Yeah.
and shame. And if they're not, some of it has to do with the inconvenience of current methadone maintenance. If you have to go to a program every day. But if we get to a doctor or provider model, like we have in Suboxone, I just don't see that. And I think you ought to take the research position on this, which is what's the evidence? Like, the evidence to me is that when you stop taking treatment for a chronic relapsing illness, you relapse you're at risk for relapse. Now, it may be that the risk is decreased by the psychotherapy or the group support, but I wouldn't assume that. So I think maybe there's insurance pressure to be off treatment, but there's certainly peer pressure. And yes, you're absolutely correct. For depression, there's no such pressure. For schizophrenia, there's no such pressure. For type 2 diabetes, there's no such pressure. It's an interesting, I learn a lot by talking to people. Obviously, I'm better in animal science translation, but in doing this impaired health professional program, and then being involved with the Board of Medicine's program for impaired health professionals in Florida, we had a 5-year contract for these doctors. So for 5 years, they had a psychiatric evaluation. If they needed treatment, they had mandated treatment. They had contracts. They had take their naltrexone or whatever, and so forth. They went to caduceus meetings, and there's a whole 5 years. The most interesting study that Lisa Merlo had done was what happens at the end of 5 years, and it turned out that even though their license was in jeopardy by participating, they signed up for another 5 years voluntarily.
Really?
So they knew they had a chronic relapsing illness. They knew that, but they still said, I feel better actively participating. Now, the difference in the impaired health professional model is, of course, it's a resource rich. The doctors have resources and they want to retain the ability to practice medicine. The Board of Medicine wants their doctors to safely practice medicine and so forth. But everyone's kind of aligned, but you don't have a situation where someone says, I can't afford it and my insurance won't pay for it. Even though, for the most part, one of the mistakes in thinking that doctors are so different is by the time they come to treatment, they usually are without resources. They're like everyone else. They burned out their family. They burned out their friends. They may have even lost their job and privileges. And my mentee who runs the program now, when I met him, he was raking pine straw, and even though he before that was a pretty prominent physician, ended up in landscaping.
Yeah. So when the illness has progressed, so you've lost even a lot of your social supports as well as professional access.
Yeah. but they know they want to be back to where they were, and it's possible. I do think it's the big difference. So people have focused on those studies and said, well, that's a resource rich, they're rich people. And I don't think that's really it. I actually think the biggest difference is the age of onset. So for physician addicts, they performed great in high school. Have to have all A's, and they performed great in college and medical school. And maybe they have substance use, but they don't have a disorder. And so I look at it mostly as the early onset, which is what we're dealing with most of the people, and physicians have late onset.
Later on, so,
And that's really, to me, is the reason that they do so well. 80% of them are after treatment back at work, and for the full 5 years that Bob DuPont and others have, Tom McClellan have followed them, they've done great. But I think that's probably, to me, that's late onset. It's harder for an addiction to develop, and probably easier to return the person to their pre-morbid state.
That's so interesting. I never thought about that age of onset kind of item to take into account. That's super interesting.
Right? Because if you start using drugs when you're 13, your brain isn't developed, and how does it even know what normal is?
Yeah.
So maybe it thinks normal is to smoke cannabis every day. So then maybe it accommodates for cannabis and then rewires itself in that way. It's the same thing, I think, that we're going to come up with for psychedelics. The all of the studies are in fully formed adults. That it's irrelevant to adolescent use. It's not. It's like a different species.
Yeah. So speaking of psychedelics, I love that you included a few of the studies. So we know that we have some new medications and tools for depression, maybe for PTSD or TBI.
Yeah.
So with ketamine, MDMA, and psilocybin.
Yeah.
So this is good news in the psychiatry field. But how do we manage some of the messaging around this instead of using therapeutic doses and seeing a psychiatrist to manage these new medications? Then we see increased use of hallucinogens, people self-administering much higher doses and at much younger ages. If it feels like we get good news and then sometimes we interpret it incorrectly and then we end up with more use disorders.
Yes. So I don't disagree. I had one article in Psychology Today on ketamine use disorder. It wasn't even considered a use disorder. I mean, Linda Kotler has a paper like, how do you diagnose ketamine use disorder? It seems crazy, but of course, the messaging is confusing for young people. Like, ketamine is an antidepressant. Well, that's a fact, but it's really Spravato, and it's a nasal spray. Now, we had recently the loss of a actor in a hot tub getting ketamine. And there are a lot of lessons in that. It's just no one listens to those lessons. The lessons would be like, you're so addicted that somebody can charge you tens of thousands of dollars for a dose. Or you're using to the point that you're a young person dying, or using in a hot tub. Like, all of it doesn't make any sense. But I do think you can't lie. You tell the truth. Like, morphine is a wonder drug, and if you're, God forbid, in a hospice, you're going to get morphine.
Yeah.
That does
that medication.
Right. So, but it's as prescribed. Somebody's prescribing it for you. When a doctor prescribes for themselves, well, Hippocrates said it the best: a doctor who treats himself as a fool for a patient.
Yeah, right.
And, you know, the same thing happens in animals. Animals get addicted faster when you let them self-administer the same drug than they would if you administered it to them.
Interesting. So I think that some of the lessons here are we have to get better at messaging. So we have to tell the truth, because we don't tell the truth, especially with, I mean, I have 3 teenagers, so we have a smart young adult and adolescent population. So we have to be accurate and honest, but also maybe more nuanced in how we message and educate that ketamine, important new medication, but that doesn't mean that it's sort of a free-for-all.
No, and in fact, it's very dangerous.
Yeah, yeah.
There's cardiovascular, it's dangerous. There's no doubt about it. Like, why did the FDA say that after it's given to you by a doctor, a health provider in an office, that you
Yeah.
have to stay still in the office for 2 hours?
Oh, wow.
Like that's the REMS.
Observation?
Yeah,
Oh,
because bad things can happen.
yeah.
Now, if you're taking it on your own, what's the control? And
Yeah.
for
Who's monitoring?
psilocybin, it's the same thing. I mean, there's a University of Virginia crisis hotline, poison hotline data that's wild. I mean, most of the poison hotline regarding psilocybin are young people, and very often it's cardiovascular.
Oh, wow.
It doesn't mean that the drug won't have a medical use, but wait, the FDA did a really nice job on ketamine. They basically said this drug works compared to placebo. It can help people with suicidal depression quickly. Now, what are the alternatives? Like when I was in training, you might put a person in 4-point restraints, tie them up to help to keep them safe so they wouldn't harm themselves. Like a person who's driven to harm themselves. Or they had quiet rooms, like padded cells in institutions. Like if you're telling me that ketamine can save a person who's just running head into a wall to try to harm themselves, I'm going to tell you that's great. I'm not keeping that a secret. But now the FDA says, but you have to give it this way.
Yeah.
This is the dose.
And
Give it
safety
as a
precautions.
nasal spray.
Yeah.
Take it as prescribed. Be
Yeah.
observed. And don't give it to somebody with a history of schizophrenia or and maybe they should exclude people with a history of substance abuse. But I do believe that the process that can protect us, but sadly, just the fact that something has a medical use doesn't mean that it's safe for you.
Very true. So that education piece. So I know that we're coming to the end of our allotted time.
Yeah, I've done I can't believe it. Like
You've done
it's
90 minutes.
inspiring. I definitely am losing my voice, but
Yeah. Well, you've been amazing
I'm
to
inspired.
spend time with us, even when you're recovering from pneumonia. But one last question, and before we wrap it up, that came in, and I tried to get through as many as we could in the Q&A. But Kathy asked, do you see any medications for addiction treatment for stimulants, for cocaine or methamphetamine in the pipeline?
No.
No. Okay.
I think that one of the reasons that Tom Costin was working on that vaccine first was that.
Okay.
The second, there are 3 separate kinds of things. I do think we could maybe do something to improve overdose treatment,
Okay.
like some enzymes that might help metabolize it better. But right now, if somebody has a methamphetamine or cocaine overdose, and they're at home, the main thing to do is supportive and if you can, lower their body temperature.
Mhm.
Because in many ways, the cause of death is like this hyperthermic crisis,
Hmm.
stroke and heart attack. Don't exercise. Like, don't exercise is not a treatment for somebody on cocaine or
Okay.
methamphetamine, because both increase the demands on your heart, while cocaine decreases the blood flow to your heart.
Okay.
It's just bad. But I think we used to pack people in ice in the emergency room. I have no idea whether they still do that. We give them fluids and try to lower their body temperature, but it's pretty much like what a parent would do with a kid who has got a febrile convulsion.
Really? Okay.
Yeah, and a lot of anyway, but I don't see that as around the corner. I think you're gonna, for right now, that's why I was saying that I think the kind of opioid use treatment programs that have been set up, they're going to need safety valve residential programs for the combined users
I love
and
that.
for the psychostimulant users.
And maybe double down on that overdose reversal medication if possible to put in that
Right.
pipeline.
Yeah.
That's a great piece. Well, I'm again, I feel like we're so lucky that we get to spend some time with such a sort of pioneer in this field. And I know that uh, our work here at APF is has so much benefit from your guidance and your mentorship.